Hello everyone. Thank you for joining us and welcome to this webinar on pharmacogenomics. My name is Patrick Charbonneau. I'm Director of Product Management at TELUS Health, and we're really delighted to have you for today's session. As you know, pharmacogenomics is quickly evolving, and not only from the technical and technological background, but also from the perspective of group health benefits. Following this session, you should have a good understanding of what is pharmacogenomics, the progress that's been made in the domain, as well as a good understanding of what it means for private payer industry, which is going to be affected by this technology. Without further ado, let's get started, and let me introduce you to a colleague of mine, someone who's deeply involved in the field, Medical Director here at TELUS Health, Dr. Michel Hébert. Hi, Michel, and welcome.
Hello, Patrick. I'm quite fine. Thank you. I'm very pleased to be part of this webinar concerning pharmacogenomics and to help people understand more where we are and where we are going.
Super. I think we're going to have a great session together. So let's jump right in. If we look at our agenda in a little bit more depth, first off, Michel is going to give us a little bit more context and frame exactly what is pharmacogenomics for us and give us some more details around that. Second, he will also go through scientific and clinical updates for us, what's the latest trends and the improvements in the domain, which are numerous, you will see. I will be going through market adoption initiatives, talking about the Insurer perspective, which, as I said, will be impacted by this technology, and we will close off with a conversation between Michel and I on what us at TELUS Health we are doing to get involved in this area. So, Michel, why don't you get us started and start us up with a little more depth on what exactly is pharmacogenomics.
Yes, I agree, Patrick. First, the terms. How could we define pharmacogenomics and pharmacogenetics? So here, as you see in the slide, people switch from pharmacogenomics to pharmacogenetics. And if you really look at the definition of those terms, pharmacogenomics refers to the studies how all the genes can influence the responses of the drug. So the whole gene and the drug as a whole. It's broader. Pharmacogenetics refers really to how variation on one single gene influences the response to a single drug. So we bring it down, we scale it down to one gene, one drug. So naturally, if you can hear in different places, or can read about pharmacogenomics and pharmacogenetics, and often they will they would switch term and not use necessarily the appropriate word, so don't be formalized with it. And it's the same thing, Patrick, about the famous personalized medicine and precision medicine. As we know, pharmacogenomics or pharmacogenetics falls into what we call precision medicine. At the beginning, we thought we would use personalized medicine to describe that field, but everybody argued that we were already personalizing the treatment with patients. So therefore, somebody said, well, okay, it's personalized, let's make it more precise. So that's why the word precision medicine came up at the surface. So again, it's also a use of term that can be switched among people talking, or as you go through the literature about those two fields.
So we won't get held up in the terms, but it's important to know exactly what we're talking about.
Yeah, these are complicated words. It gives lots of points at different games, like which one that we usually play there. Scrabble, voila. Yeah, Scrabble is a good word. So here you have also, how do we place, where does pharmacogenomic reside in this world? So on the left side, the genomic world. So as you can see, the second one, the pale blue, is called pharmacogenomic diagnostic testing. But in this nice world of genomics, you can also have the prenatal DNA that you probably heard about, the pre-implementation diagnosis, the oncology. Oncology is big. It's been widely used now in many types of cancers to ensure that the diagnosis is precise. Afterwards, you have the drug metabolism, which is part of pharmacogenomics also, the identity diagnoses and the forensic medicine. You see that in all those shows that we see on TV, where they use the genomics world technology to identify the crooks. And you have also the newborn genetic screening, which is big. Rare diseases is big on the agenda of many pediatric hospitals and or treatments. And finally, the infectious disease diagnosis. So these are different genomic, and then there are other ones, but these are the ones that seem to have traction in the scientific world, in our society. And as you can see in the graph here, it goes right up to 2022. The implementation of the technologies in those fields shall increase through years, which will bring other challenges in treating patients or coverage of those patients that have insurances. On the right side, you have also where does the genome world stand in the different layers, because we've noticed that even though you have the genetic profile of a person, it will happen that the results or the clinical results you obtain by treating that patient or undergoing different investigations, you will find out that they don't necessarily follow, the results don't necessarily follow your findings on the genetic profile. And why? It's because above the genome, you have, with the genomic world, you have some layers that go up. You have the transcriptome, the proteome, the metabolome, the microbiome, the epigenome, or the exposome. So these are all layers of factors that could influence the genome, as social activities and biosensors could also have an impact on. So these are all factors that make genomic science or genome science not exactly the 100% truth on which we could base a treatment or a diagnosis.
Yeah, so the genetics may be the same, but the repercussions or what we're seeing on the outside changes depending on those pieces of the environment and around the body.
Yes, absolutely. So that's why it's important to understand that even though some position the genomic world as the ultimate goal we have to achieve, we have to remember that we have to look around and see where the patient lives and what can influence the patient in his day-to-day activities to make sure that we understand what kind of best treatment we can give.
Great stuff.
Oh, and now, naturally, talking about genome, well, also, it's not magic. Eh? You don't give saliva and there's a black box and suddenly you end up with a result. So first of all, we have what we call on the right side bottom. We really work on DNA to data. That's so how do we go from the DNA sample of the patient to getting his data? So in pharmacogenomics. So technology has worked hard to improve the way we detect, or we describe, we isolate the pharmacogenetic profile of a patient. So we use wells on a microarray, which is a kind of a device that looks like an egg shell, not an egg shell, an egg holder. Thank you. So each well will have different reactive and markers. So we started doing one marker per well, and now we're at 36 markers per well, so it's going very rapidly. And the more markers you can put in a well, the quickest you'll get the results. And because, as you can see, we can go up to 350 markers, and sometimes higher than that. So, as we speak, when you do a test, it takes about 8 hours for a test, from the DNA to data. So everybody's working hard to bring that time shorter, and increasing the wells and the markers will also bring the test cheaper, as we can see in the next slides that we'll have.
Each of those markers gives us indication on the reaction for a molecule or a drug, and obviously the more markers we have in the same well, the faster we go. Correct?
Yes, absolutely, Patrick.
Super. And the faster we go, the lower the cost, right?
Hey, Patrick, you're so right. So here you see, on blue or dark blue side of the curve, that's the curve to test the whole genome sequencing. So it went to $1 million to $250 through time in about 12 years. And on the green side, you have the cost also going down for pharmacogenomic testing. So it went to $1,000 to down to $175 today. Naturally, that will be the production cost because the commercial cost it will probably be a little bit different than those basic prices.
Excellent.
But it's going down. That's the good news.
Yeah, that's the good news. And we're in the more affordable ranges, and some companies go into these things to make a point to the market, right? Try to wake up the market a little bit and increase the usage.
Yes, exactly. So again, on the left, you have another curve showing the genome sequencing cost that goes down through time. And the company Cambridge-based Veritas Genetics, just at the end of November and December, they offered their whole genome sequencing for as low as $199, which is it was for a short period, but still it's quite down from the $1,000, which is above the regular price or the real cost of a test across the world. And but they are sending this message, like they say in their release, that genetic testing, the whole genome could go down as low as $99 per test in a foreseeable future. In a short future, not in a foreseeable future.
Great. And so we know the tests are going better and better, getting faster, getting more affordable, which is why we're here today, actually. If they weren't going in that direction, we wouldn't see the interest we're seeing today. And if we try to picture ourselves in the future even further, what we end up, really, when we're doing those tests, and then, Michelle, you correct me if I'm wrong, but I think I'm right, is we get a single report describing the complete genome-drug interaction profile. So meaning the patient walks away with a very good understanding or a complete picture of how their body interacts with the molecules and the drugs that are available. And so what we anticipate is in a not so distant future, patients will be able to carry, so to speak, their report and share the access with healthcare providers that can help them make the best choices for their medication. Obviously, we're talking about family physicians, specialists such as psychiatrists, pediatricians, oncologists, pharmacists, and other healthcare professionals as well. So really putting the patient at the heart of controlling access with the proper consent and proper security mechanism.
Yes, and also, Patrick, one of the challenges we have in healthcare is the size of a report for pharmacogenomic profile or genome profile, and this size will entice us to look at a model where we won't have to copy that profile in each database, like hospital, pharmacy, or a few clinics where the patient will attend to get his treatment. So the best way to envision that would be to have one repository where all the data is in it, and as a healthcare professional, I can access with the consent of the patient to that database and proceed to the proper analysis to treat the patient. So that would prevent those profiles to be copied and be saved on many different databases, which would increase significantly the room needed to host the data of all the patients of a clinic, for example.
Great. And on the side, you also see insurers listed with a question mark. And the point here is we have the healthcare providers who are going to be directly using the information to help the patients guide their choices, but we also have other entities, service providers, who are going to benefit indirectly from the technology. The question still lies as to whether or not they will have access to the results, and we're going to talk about ethics and privacy and law and regulation in a couple of minutes, but there's still that question mark around who else may have access to tests, but definitely there are other stakeholders in the healthcare ecosystem that are going to benefit from these tests being used to accelerate selection of the proper drug, of the ideal drug for patients. Obviously, that's a nice picture. We're not quite there yet. We've got some challenges we still need to overcome. We've listed 5 of the biggest challenges here on this slide. First off, the testing. We talked about it already. The testing needs to continue to get faster and even more affordable, more accessible. That's one aspect, but we see really positive trends here, and I think we're on definitely the right track. At the other end of the slide, you see the concept of and the challenge of ethics and privacy. If you're sharing something as private and personal as your genetic code, you want to make sure that that is well regulated, that there's a framework around it, and that it is secure, and we are following the rules that are guided by the society and the regulation. And we'll talk about that. There are laws that came into play. There's also guidance and regulations around how the tests are performed. We'll go through that in a minute. And in between are the challenges for those who need access to the tests and are going to be leveraging and using these tests every day. And Michelle, I think the physicians are at the heart of these challenges right now.
Absolutely. And I think for example, education, poor training of current and future healthcare professionals on pharmacogenomics, that's really a big point. We've seen at the HIMSS 2019, that was 2 weeks ago in Orlando, we see now young doctors coming out of university and starting their practice, and they've been exposed to pharmacogenomics. So those ones, for them, it's almost a standard of practice. So they are pushing the envelope to have proper tools to make sure they can manage their patients with pharmacogenomics as one of their two diagnostic tools and treatment tools. So and they are putting pressure among their colleagues when they join the clinic, which are not haven't been trained on pharmacogenomics. So this is a big one. And the point of care education resources, again, it's always the challenge of managing that data in such a way that the clinician won't lose time. Maybe will not gain time, but at least the adding this has to be in such a way that at least it takes the same time to treat the patient. So we have to make sure that we improve the process of what is actually done or made by the physician to incorporate this new activity and not lose time. So these are really big comments. Now, when you talk about testing, Patrick, there's also a push to go to direct-to-consumer for pharmacogenomic testing. And as you know, in Canada, when you talk about labs that are providing pharmacogenomic testing, they require a doctor's signature or a doctor's prescription as we speak. So even though they do lots of marketing towards the patient, there's still a hurdle to cross. Is how do we?
That's a major difference between Canada and the U.S. we're seeing today. We're going to talk about Canada versus the U.S. in a minute.
Absolutely, you're right. So and again, in terms of informatics, naturally as we speak, there's no easy way to manage pharmacogenomics into the EMR or the electronic medical record and the pharmacy system. So this is that's also a roadblock to implementation of pharmacogenomics. So there's informatics, there's the clinical work also. Like I said a few minutes ago, pharmacogenomics is certainly an important field and brings lots of knowledge, but we still need more research and more data to bring the results at a level where every clinician feels comfortable using the data.
Because right now, again, the way the tests are coming out, there we have PDF reports that are not integrated in the electronic medical record, so you need to look at them on the side, and I believe they can be time-consuming to consult and interpret, right?
Yeah, and there's some solutions the physician or the pharmacist could use, but they're standalone. So since they're not attached to the system, that's, like you said, it's either a PDF or use a standalone application, which is not convenient.
So for the workflow, it really needs to be integrated into the practice management system, either electronic medical records or pharmacy management system, depending on the healthcare.
And also for proper documentation of the patient encounter.
Absolutely. Let's come back to a little bit of the regulations, law, ethics. As we mentioned, this is a highly sensitive topic. Genetics is obviously certainly one of the most personal pieces that we share of ourselves. And there's a new law that came into play in May 2017, the Genetic Non-Discrimination Act, GNA. Some of you may recognize it as the Bill S-201, which was the name before it became law. Essentially, this governs how pharmacogenetic testing is to be done and transmitted through the different parties and stakeholders. First of all, the law is very clear. Each test requires individual consent by the patient, and we've just seen that a test does contain a lot of information, and your genetic profile does not change. So the test, it's not like we're going to do tests every day, but nonetheless, the law is very clear. You need consent for every single test that you do. It also structures what providers of goods and services and employers can and cannot do or ask from employees and customers. So, for example, providers of goods and services cannot request or require that a person undergo a genetic test. It cannot request or require the disclosure of a previous or a future genetic test result. And those providers of goods and services include insurers. So really the intent here is to put the patient in control of who they are sharing these results with. In terms of the employers, same rules apply in terms of requesting or requiring genetic test results from an employee. In addition, they cannot discriminate based on genetic test results for decisions such as hiring, firing, job assignments, or promotions. So really, this law becomes an extension of the Canadian Human Rights Act, which bans discrimination, and genetic characteristics are simply an addition to this Canadian Human Rights Act. The punishments can be severe. We're talking about up to 5 years of prison, of jail, and a fine up to $1 million for conviction on indictment. So really, this is a serious offense if you were to not obey. Element to also take note of is in Quebec, the government of Quebec has referred the legislation to the Court of Appeal, actually questioning whether or not it's constitutional, simply because the domain insurance is regulated at the provincial level, not the federal level, and the GNA actually then interferes with that area of expertise, or that domain of expertise. And the LHIA, the CLIA, is supporting Quebec's position that the legislation seems to be unconstitutional. And so we'll follow that. It's currently in the hands of the court, and we don't have the outcome yet, obviously, but something to keep an eye on. However, the law is very clear, so you've got very clear indications of how to obey, and it shows that there's a lot of sensitivity around simply the presence of a test. What does the presence of a test reveal on an individual? And instead, I think we've got experience in the past where some tests were highly sensitive, and as the use increased, that sensitivity toned down over time.
Absolutely, Patrick, and maybe some people on the webinar remember that when HIV testing started many years ago in the 80s, it was when an insurer would find a copy of HIV lab result, even if it was negative, in a file, it would have an impact. Everybody was writing about the fact that it could have an impact on the health assessment of that particular individual. So through time, now many years later, we do, as physicians, prescribe lots of HIV testing, especially when there's a new relationship between a couple, and they want to make sure that everybody is kind of safe. Let's put that in brackets. And so you can find in many files HIV testing results, and it's not related to a lifestyle. It's related to the fact that people want to be checked before entering into another relationship. So you can see how the perception of HIV testing has changed through time.
Great. And so, so the law is very clear, but obviously the perception will evolve over time, and the more the test is used on different use cases, the less specific the meaning will be.
Yes, and I think what is important today is to share data without the consent of the patient. This is quite important. And I think with the proper tools, the proper consent structure framework, I think we could probably have the patient control who accesses to his data and make sure that in the medical file we still provide enough security so it's not shared with anybody that will want a copy of the file.
Correct. Let me pause you for a minute, Michelle. I think we have a question.
Yes, we do. So the question is, what does TELUS do or plans to do to facilitate integration of pharmacogenomics reports with the existing informatics systems?
That is a great question. It is
a wonderful question.
I'll give you the 3-second answer now, and we'll go into the details on later slide. But as some of you know, we have a lot of electronic medical records, and we are very much involved in identifying how these lab results will be accessed and accessible within the electronic medical records. Not only for our EMRs, but for the entire EMRs out there. So we are getting ready to make things available, APIs available, so that we can share that information. And we'll go in depth on a future slide, later in the presentation. But long story short, we're deeply involved in getting that integrated into the practice management system.
And a question for Michelle. Will a person's genome test results change over time, or does it stay the same?
That's also a very good question. Yes, when you look at companies that are providing pharmacogenomic testing, they more or less on a monthly basis, they update the profile of the patient, and there's different systems where they either send an advice or an alert to the patient saying, oh, you should check your profile, it has changed, because you're right. Those profiles have to be updated as we discover new evidence of interactions or gene-drug interaction or drug-drug interactions. So yes, the vast majority of companies offer an update of the pharmacogenomic testing. So when the patient will go back to his doctor, the doctor has to be also, the physician has to be, has to make sure that he will redo the test, the interaction system, use the interaction system to make sure that it's up to date. And if they were changing, you can capture that in looking at the new report.
So the genetics may not change,
but also that makes the system, the communication system between the patient and the doctor through a PDF form very cumbersome.
Another question for you. What are the plans to educate present healthcare providers, as the greatest barrier to implementation of pharmacogenetic recommendation is the treating doctor?
Oh, I like that one too. Gee, people are up to date here. That's great. Yes, well, we at TELUS, with the project we have that we'll talk about how we want to implement the different...
Why don't we talk about it now?
Oh, certainly. Go ahead, Patrick.
Well, the plan is to part of the supercluster, right? That's where you were heading?
Yes, and also I'll add on the supercluster for the education side.
Yeah. So one of the big questions is just around the ecosystem, right? We're talking about education, access to tests, and so on. It's unclear at this point how exactly the whole system will evolve. We've got a number of test laboratories that are active on the market. The market is very young, so we're keeping an eye on what's happening here. The patients clearly access the lab results through their physician currently right now, and in terms of the payers, the public payers, the government needs to step in. Private insurers as well, they're starting to see the claims come in for the lab results. But the real challenge is, again, in terms of using those tests, making them accessible. And TELUS is involved in one cluster, one of the superclusters, to really identify a process by which all the EMRs and the practice management systems could integrate those results and make them available to the physicians and the pharmacists. Now that involves as well an education aspect because, the technology needs to be there, but the understanding and interpretation needs to be there as well. And that's where I think the question came in.
Yes, as a matter of fact, so with Supercluster, by creating this platform and hooking or connecting everybody on it, there's a partner we have which is Genome BC, and we are partnering with the NHS in England, where they have a whole package of education for healthcare professionals and also another package for population. So we are planning to integrate those packages, that education side of Supercluster, to make sure that we can expose as many healthcare professionals to pharmacogenomics. Also, in an effort to inform population, we are in contact with all the colleges of physicians across the country, and we are interacting with them in such a way to provide as much information as we can give them, agnostic naturally, but to make sure that they could use those packages and put that into the CME systems because there are lots of variances from province to province, but to incorporate that into the CME activities.
Great. A topic we wanted to touch on was some of the subtle differences between.
Just a minute, just to add, and I like that question about education because, unfortunately, what came out on the market and what we were exposed to as primary care physicians in our offices is predictive medicine, and which is not necessarily where we want to go first. And there's a lot of debate about predictive medicine. So that put a little bit of shadow on pharmacogenomics. So we have to strike the record right and bring proper information about pharmacogenomics.
And just to be clear, predictive medicine being the fact of being able to, make a diagnostic based on the genetics versus simply providing information on how, the patient would respond to a particular drug and letting the physician make the assessment. Am I right?
Yep.
Great. And some of that came up as well in some of what we heard through the media, and was also the result of some subtle differences between the Canadian and the U.S. standards. So in Canada, tests are regulated by two bodies. First of all, the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use, prefer the use of RCH, and Medical Dictionary for Regulatory Activities, the MEDRA. And so these two bodies really structure how the tests are to be performed and the kind of information that are provided as well. In the U.S., it's a mixed bag of two different things. We have the Food and Drug Administration, who regulates in vitro diagnostic devices, IVDs, and provide similar guidelines and regulation. But you can also find some tests that are the result of industry best practices or covered under the Clinical Laboratory Improvement Amendment, which are sometimes referred to as home brews, and those can vary a little bit more from laboratory to laboratory, and our aim sometimes is direct to consumer markets, which tend to go beyond simply providing basic information.
We do have a question concerning this. Is there a website that would allow someone to check which laboratory provider has certification for these tests?
Yes, absolutely. Well, first, in USA, you have an FDA, there's an FDA site. On the FDA site, you have on the section Pharmacogenomics, you can see which labs are been accredited or being authorized. And in Canada, it's on Health Canada, the same way. There's a place where you can have a list of certified labs.
And another question is, can you expand on the rationale why a genome test requires the physician's consent? It's my understanding that anyone can arrange for a genome test without a physician's involvement.
Yes, it's a very good question. Well, if you look at the different, first of all, if you look at different labs, like Life Labs or other labs across the country, they will require a prescription from a physician to perform the test, which is not the case in USA. That's why if you send a sample of saliva to 23andMe or Ancestry.com or other companies, and they will take it. But in Canada, in BC, Quebec, and I think in Ontario too, the actual standard is to provide a prescription from the physician to have a test performed, a pharmacogenomic test performed in a clinical setting. If you talk about predictive testing, that's another field, another market, and the law doesn't apply the same way depending on the province.
Great. So we've seen that the ecosystem and the environment is still in flux, but some players are still moving forward with pilots and trying to see exactly measure the kind of impact we can have with this technology. One of which is in the pharmacy environment. One of the interesting pilots was the I Can Pick, where 2 community pharmacies in the Toronto area opened the option to pharmacists to get pharmacogenomic screening done, and the pharmacists look for specific reasons to trigger that test. For example, ineffective therapy, to address adverse secondary reactions that were causing trouble to the patient, and simply guide initiation of the very first therapy with very interesting results. So out of the patients that were where the testing was performed, an average of 1.3 drug therapy problems were identified, which seems to indicate, we could really help those patients. And some of the recommendations, most common recommendations, were a change in therapy at 57%, dose adjustments at 14%, and discontinuation of a drug at 7%, as well as increased monitoring at 20%. So really a sign here that within a community pharmacy environment, having access to this test can really be helpful for a specific group of patients. So interesting results that we have here. On the Insurer front, pilots are also moving forward. Sun Life was the very first to actually join a study, the IMPACT study, a very large study at that, with over 9,000 patients. And we don't have the specific results from Sun Life yet. However, the IMPACT study did release some of its partial results, and what we learned is out of those patients that were directed to genome-directed treatments, 27% of them reported a decreased symptoms or feeling better after 8 weeks of treatment, which is a great accomplishment, because they were still, they were already on treatment. So very encouraging signs there that we can help patients and guide them to the best treatment fairly quickly. Great-West Life also launched a pilot in early 2018. They haven't released their results yet, but they're already giving us indications that they are seeing very interesting results with patients that have simple pharmacogenomics profiles. And by simple, we mean monotherapy or singular health issues, so that once again, the genetic testing can be more precise, the genetic results are more precise and simpler to interpret. And I think that's aligned with some of the results you're seeing in the field. Right, Michelle?
Yes, absolutely.
So these are some of the pilots that have been happening in the pharmacy and in the Insurer world. On the clinical side, physicians are also doing pilot projects to identify who is best positioned to benefit from this technology. And I know you're involved on that front. Michelle.
Yeah, absolutely. We did a pilot here in Quebec, and we took a community pharmacy, a regular one that treats, has from patients from newborns to 99-year-old patients, and the average community pharmacy. And we did use a risk assessment tool and we processed into that tool the 6,800 patients to see what kind of risk they would have according to the medication they take, what kind of risk they would have for adverse drug reaction related to drug-gene interactions. So this is the data we obtained from that particular pharmacy. So as you can see, more than 67% of the patients had a very minimal risk of interaction during drug-gene interaction or gene-drug interaction according to the medication they take. And as you go clockwise, you can see there was 19% with small risk, 10% with average risk, and finally 4% with high risk. So from this study, this pilot, we were able to test, to focus on testing the patients that you could get the best result for the money you invest in testing. And by the way, I made a mistake a few minutes ago because also, depending on the provinces, pharmacists can prescribe the test, not only physicians. So I would just want to make sure that I correct that. So in this case here, we did study the 4% high-risk patients that were expressive as a risk, and yes, they were all having. We could describe for them after doing the swab analysis, the saliva swab, we could identify they had a high risk adverse drug reaction. They had adverse drug reaction in their profile. Yeah.
So
go ahead, Patrick.
So at a high level, we can say there's a potential of 4 to 14 or 15% of the patients that we can very likely help by using the technology to focus and maybe improve the medication that they're taking currently.
Yes, and as a matter of fact, it's a learning process for the pharmacist and the physician because which is interesting here, depending on the condition the patient had, we could do the appropriate correction on their medication profile, and that's a learning process because having a patient that you can find safer medication for a maximum therapeutic effect. So as a physician and a pharmacist, you can maybe narrow a little bit your choices of prescription for certain disease if you don't do pharmacogenomic testing to at least bring the adverse drug reaction to a lower risk for each patient. So that's the learning process too.
But at 4 to 14%, we're not seeing a tsunami of tests coming our way.
Absolutely. That's the greatest lesson to bring back home from that pilot project.
Super.
We have a question here. On November 1st, 2018, the FDA posted a statement. The FDA warns against the use of many genetic tests with unapproved claims to predict patient response to specific medications. Any comments on that?
Pardon me. Yes. Well, there's maybe 14,000 different medications, and there's a handful that are tested. And on a daily basis, there's more and more. And like I said a few minutes ago, the clinical evidence around some of the reaction, there's a gray zone. It's not clear what is the real clinical outcome. That's one thing. The second one is, pardon me, is to use pharmacogenomic testing and market the tool in terms of predictive medicine. For example, out of the blue, let's say you have a panel and you find something about anticoagulant therapy. That's a big one, warfarin. So you have high metabolizer and low metabolizer, and you could say, oh well, you better watch out because you could suffer from deep venous thrombosis depending on your profile, which is not really the case. There's a link they make between the predictive value of a disease and the pharmacogenomic testing, which is not accurate. So this kind of marketing around the test does shed shadow on the value of pharmacogenomic testing. So that's one of the reasons why so there's two reasons. First, the new molecules they discover, or the new findings they have, and second, the way they advertise or they want to promote those tests in the market.
Thank you. So something else we wanted to show you is some of the potential impacts on the private payers and on the insurers that this technology can have. And there's two use cases we wanted to bring to your attention. Michel mentioned this, I think, in passing. 4 big categories of the drugs that are targeted with the pharmacogenomics currently: depression, cardiovascular troubles, anticoagulants, and which is the fourth one again, Michel?
Pain.
Pain, exactly, pain control. So 2 examples I want to bring to your attention. The first, anxiety and depression. What I've done here is I looked at all the claimants in the TELUS book of business for drugs under this category in 2018. You can see we've had just over 1 million claimants for anxiety and depression drugs, 410,000 roughly new claimants, which indicates to us this is a type of drug that patients take on a temporary basis. Interestingly, we also had almost 30% of patients switch drugs, of the new patients switching drugs, within an average of 72 days, which tells us we have 30% of the new patients which have suffered from 72 days of, shall we say, suboptimal performance, and clearly we're not feeling as well as they could have. And we know that people under depression can have a certain effect on productivity. And so a story here, an article that we picked up on, reveals that in a 3-month period, patients with depression can miss an average of 4.8 work days and suffer 11.5 days of reduced productivity. So if we go back to the goal of pharmacogenetics, which is to speed up or accelerate the selection of the optimal drug, we have an opportunity to help those 30% patients get back on their feet quicker, hopefully improve that 11.5 day of lost productivity, and get back in the workplace more active and feeling better overall. So not only is it better for the patient, just in terms of their general health, but from a financial standpoint, given the test is roughly $200, even if we're not helping everyone, clearly we can have some economic value for the employers, given the very significant impact of depression and anxiety that is seen on the workplace. So an example where pharmacogenomics can help getting people back on their feet and have a positive impact on their health and productivity in the workplace.
And like you said, Patrick, with the cost of the test going down through time, there's a kind of probably where the 2 curves will cross and it gets more cost effective.
It almost becomes at some point a no-brainer to be leveraging it across the board to make sure that we are getting people back on their feet as quickly as we can. You're right. The second example is on cholesterol control, so on the cardiovascular category. A different use case altogether. Again, I pulled out the claimants from 2018, and what we see here is we have very different cost profiles for some of these drugs. So on average, the claimants have an average cost of $119 for cholesterol control. We do have a specific drug, Repassa, which is much more expensive, in the range of $4,000 a year. So 20 times the cost. And so the point here is, for the physician and for the patient, as well as for the insurer, to be honest, there's really an interesting point here in trying to leverage the pharmacogenetic testing before we, for example, try such an expensive drug for even a limited amount of time, and ensure that the drug will have the benefits we're looking for before we undergo that treatment. And there's a couple of reasons for that. Obviously, the insured doesn't necessarily enjoy having a $4,000 claim, much prefer the $120. But I would say that patients as well, right? Their out-of-pocket is much higher, and we want to make sure that the results are there, because a script that is not being taken by the patient for cost reasons, for example, is a real problem and something that the physicians and the patients need to avoid. So here's a different example where the cost of the drugs, is this driver to make sure that we are using those most expensive drugs in the most appropriate use cases. Michel, is there something you want to add here?
Well, it emphasizes the fact that at the point of care, if we wanted to help the treating physician and the pharmacist, we must provide in their EMR or their pharmacy management system proper information at the right time, that you can have quick reference or different ways to inform the healthcare professional that the decision they're about to make has an impact on the patient's treatment, and that could be one motivator here.
We have a question here?
Yeah, we do. This goes back to the Genetic Non-Discrimination Act. So are claims adjudicators included under that act? If a patient consented to sharing their information, could the adjudicator use the information to flag, for instance, a drug interaction?
So the law is very specific on the fact that the adjudicator cannot request access. So I think that's where the challenge is, even with the question in the use case, which is, will a patient offer access without a carrier asking for it? And the whole question is there, I think. In theory, if a patient would offer access, the law doesn't prevent you from using the data, but it does prevent you from asking for it. So I think we're a bit of in a catch-22 on this one from my perspective. Michel, what do you think?
Well, I think the question is very good, because surprisingly, some patients do want to offer their profile to every partner they interact with, or every business partner they interact with, and those cases are super difficult to solve. It's all about the consent. Is it a real consent? Did the patient understand which consent he's giving, and what are the impact of that consent? And this is where
feel pressured, for example, or did he feel pressured to give the consent?
Oh, yeah, but he can feel pressured, and he can say, "Oh, I don't mind giving that consent. I don't mind giving them their system," but he doesn't really understand the impact it will be. Like, it could cut his life insurance by half, or it could, to the impact of what he's doing. Even though he is open to give it, he really has to understand. And there's definitely legal cases on this that went up to court where the patient said, well, and especially in research, he said, well, I didn't understand the impact. It was not explained to me what would be the impact if I would release that information to a third party. So
we're going to see those situations handled with much care in the coming months or years.
Oh yes, absolutely, and it's a very good question, because among us, you can see how people consent to lots of stuff, and I'm always amazed to see how generous they can be to spread some of their information, personal information, without really understanding the consequences it can have.
We're already almost at the end of our webinar. This is our very last slide, Michel. And what we wanted to do with this is kind of summarize some of the facts, the unknowns, and give you an insight on the strategy that we're taking at TELUS. And we're almost at the top of the hour here. So just to summarize quickly, in terms of the facts, I think the science has been very clear, and Michel, you talked about it. Pharmacogenomic genetics can help identify the best drug for the patient, especially with monotherapy and mental health, as long as other areas of health are particularly targeted currently for these interventions. However, obviously the data shows as well that it's more challenging to use pharmacogenetics when we have multiple health problems, because there is this combination that happens and the interpretation becomes a little bit more difficult. And in terms of the unknown, well, we still don't know how fast the tests will increase just in terms of the prescription numbers. What we do know, however, is it's going to require a significant improvement of the integration with the practice management systems, the electronic medical records and pharmacy management systems, in order to get to a level where it becomes part of the routine, it becomes part of the workflow, and it's something that's easy accessible to the healthcare providers. In terms of the sales point, still unknown whether or not where the patients are going to be doing those tests. Is it in a pharmacy setting, directly in the doctor's office, or in a lab facility? and we're keeping an eye on that, obviously, in terms of the evolution of the ecosystem. And in terms of our strategy at TELUS, well, the first thing, and Michelle, that's where your team is very deeply involved, is implement technology that makes it easier for physicians to adopt pharmacogenetic testing. By integrating into the EMR, by improving the education, our involvement in the supercluster is all about that, and we are making our technology available to do it through our TELUS Health Exchange, making sure that we are offering APIs that are open to us and all vendors, to be honest, across the industry.
Yeah, and as we mentioned, physicians, but also pharmacists.
Correct, absolutely. And so what we're going to be doing is observing those trends, and on my side, I'm very close to the insurance world, and we're looking at what possible claim solutions we can bring to the market to bring electronic claims adjudication to the market. Is it going to be through extended healthcare type of claims? Are we going to be leveraging e-claims, which some of you may have? Is it going to be CPHA protocols, which seems a little bit more likely given it isn't the test is not a drug, but we're still keeping an eye on that, because if it does happen through the pharmacies, it will be a fair question to ask. So I think we're more in a observation mode currently, and we will be updating obviously our roadmaps and making plans to bring an electronic solution to the market for adjudication of these test results. So
we had lots of good questions. I thank everybody that listened to the webinar. Thank you so much for asking all those great questions. Maybe there's more. I don't know.
There are quite a few more, and unfortunately we're right at the end of our time. And you can always send us the question via email at telushealth@telus.com, and we would be happy to respond.
Okay, that will be great.
So closing words, I do want to thank you for your participation today. Great interaction as well. So much appreciated to have these questions as we're going along. I think this is clearly a topic of interest, a topic I know we visited in 2017, and we're visiting now, early 2019. I think we'll be visiting again, if not in 2019, early 2020 for sure.
By the way, just before you speak, Patrick, I'll just make sure that there's a lovely voice you heard. It's Mary Ludovico that has organized this webinar, and we thank her warmly for all what she did, and it's, again, top-notch technology that she's able to master. So thank you, Mary.
Thank you very much.
Thank you, Michelle.
Yeah. There are some people working in the background to make this happen, and it's much appreciated. Some very quick reminders before we let you go. Mary mentioned it. Send us your questions at telushealth@telus.com if you have some that we haven't been able to answer. Your webinar does entitle you to one continuing education credit, which will be sent next week by email to those who have participated to the presentation. Thank you, Michelle, for participating today. It's been a pleasure preparing and doing these webinars with you. So thank you very much.
It's always a pleasure. Thank you so much. And thank you, everybody, for attending the webinar. And unfortunately, it's not the last of us. You'll see, because we'll certainly come back by the end of the year with an update on that marvelous field of pharmacogenomics.